Hello, we are back. It took us a while, but we are back and we are ready to deliver another content. And today we will talk about germ cell tumors. So we still continue with our effort to address the more complicated topics. And I think I can start with the same sentence as usual. The biggest problem with this topic is to understand what germ cell tumor is. So the biggest problem is the definition, the proper definition, and the pathogenesis of such tumors. And if you understand that, if you understand what defines this group of tumors, and if you understand the proper pathogenesis of these tumors, I think you will be safe, because from that time it will be just about, I don't want to say memorizing, but it will be about knowing a few sentences about each tumor, what is the clinical presentation of these tumors and how they look like, what is the morphology. But the biggest issue can be with the proper definition and proper pathogenesis of these tumors. So let's start. Small disclaimer at the beginning. And now the definitions. Before we can define germ cell tumor, we need to start with the definition of germ cell generally. Because broadly speaking, if we will talk about organisms that reproduce sexually, generally, human beings included, in these organisms, germ cell is any cell capable of giving rise to gametes. In other words, germ cell is any cell capable of meiotic division, of meiosis. And at the end, the cell is able to give rise to new organism. And maybe you remember from embryology that when the sperm and oocyte merge and the new organism will start to develop, the early embryo consists of 3 so-called germ layers, and these layers consist of germ cells. We've got ectoderm, mesoderm, and endoderm. And each layer gives rise to different somatic tissues. Ectoderm gives rise to a central and peripheral nervous system and skin with skin appendages. Mesoderm gives rise to muscles, connective tissue, cardiovascular system, bones, reproductive and urinary system. And endoderm gives rise to respiratory and GI tract. But apart from that, there will be a group of germ cells which do not differentiate. They stay on the level of immature totipotent germ cells. So there is a block of differentiation in this group of germ cells, and they subsequently migrate to testicles and ovaries, to developing testicles and ovaries. And this is how the pool of germ cells is ensured for the next generations. So there is a block of differentiation in some germ cells that don't differentiate into the mature somatic tissues, but they stay on the level of immature gonocytes, basically, and they migrate and seed developing testicles and ovaries. And this is also explanation why some germ cell tumors can arise from extragonadal localization, such as mediastinum or retroperitoneum, because some cells can be stuck somewhere on the way and they can give rise to, for example, teratoma or seminoma in extragonadal localizations. And germ cell tumors basically recapitulate this pathogenesis, this way of differentiation. So if you understand this, you will be able to understand a classification of germ cell tumors. So the germ cell tumors represent a group of tumors arising from totipotent germ cell, from neoplastic germ cell, and they are capable of differentiation towards various somatic and extrasomatic tissues, which means trophoblast or tissue of Yolk sac, for example. And as I said, in case of germ cell tumors, these cells recapitulate the aforementioned developmental process of normal physiological germ cells. So even the neoplastic germ cells can stay on the level of completely immature cells without further differentiation, and such tumor is called germinoma. It is usually found in testicles, which is the most usual localization, and in testicles we call it seminoma. It can be found also in ovaries, which is quite rare, and in ovaries such tumor is called dysgerminoma. But it's the same tumor, it's just different name, but it's the same tumor. And if we find this tumor extragonadally, in extragonadal localizations, we call it germinoma, just generally germinoma. But a lot of people call it seminoma as well, so you can come to the names as a primary seminoma of CNS or primary seminoma of mediastinum. Okay, so this was the first line, so no differentiation. But the cell can start to differentiate, and it can differentiate towards extraembryonal tissues. And this line of differentiation gives rise to choriocarcinoma and Yolk sac tumor. Choriocarcinoma consists of cells that differentiate towards trophoblast, and Yolk sac tumor consists of cells that differentiate towards Yolk sac tissue, allantoa, and extraembryonal mesenchyme. And last line of differentiation is embryonal. So this tumor differentiate towards various somatic tissues, various tissues of our body. In embryonal carcinoma, it means that the neoplastic cells are stacked on the level of very immature embryonal cells. So it's embryonal tissue, but the tissue is very, very immature. And in teratoma, it means that the cells have a capacity to terminally differentiate towards various somatic tissues of our body. So it's usually a mixture of various somatic tissues such as skin, adipose tissue, respiratory tissue, and many others. If all the tissues in teratoma are completely fully differentiated and basically they are undistinguishable from their non-neoplastic counterparts, it's just a mixture, it's just a haphazard organization of completely differentiated tissues, we call it mature teratoma. And if some of the tissues, some of the somatic tissues are immature, they are not fully differentiated, we call it immature teratoma. So this is the basic classification, which stems from the developmental process of germ cells. And if you understand this, I think you are safe, because from now on it will be about the individual tumors. What are the general clinical characteristics of germ cell tumors? Well, first of all, we should keep in mind that the majority of germ cell tumors is malignant. Basically, almost all of them. I don't say all of them, but almost all of them are malignant. But it doesn't necessarily mean that the prognosis is bad. For example, seminoma is malignant tumor, but the prognosis is usually very good. The typical localization is gonad, testicles, ovaries. But as I mentioned earlier, some germ cell tumors can also be extragonadal. They can arise in extragonadal localization, and it's usually body midline, from the brain, across mediastinum, retroperitoneum to sacrococcygeal region. Especially the tumors in sacrococcygeal region, they are usually teratomas, and they are usually congenital. The typical age setting is adolescents and young adults. There are some exceptions though. Typical example is Yolk sac tumor. Yolk sac tumor, it's usually a part of mixed germ cell tumors, which we will describe in a minute. But we can have also a pure yolk sac tumor, which is quite rare, and it typically affects very small children up to approximately 2 or 3 years of age. So there are some exceptions, but usually this group of tumors are typical for adolescents and young adults. So if we want to specify it differently, it will be about adolescents and young adults. The basic classification is like this. We can subclassify germ cell tumors into seminomas and non-seminomatous group. It is quite weird classification because on one side you've got just one tumor with some subtypes, and on other side you've got basically all the other tumors. But this subclassification is quite important. I will explain why in a minute. And the second classification is pure and mixed germ cell tumors. Why seminomas are excluded? It's because the seminomas are malignant. They are malignant, but the prognosis is very good. The distant organ metastasis is a late phenomenon. They usually, if they metastasize, they usually spread into regional lymph nodes, and there is a good response to chemotherapy and radiotherapy. But the non-seminomatous group of tumors, if we will talk about them as a whole group, the majority of them is malignant and more aggressive than seminomas. Again, there are exceptions. For example, some teratomas are benign, but as a group, they are usually more aggressive than seminomas with early metastatic spread. So it's always necessary to be sure that you are looking at a pure seminoma. For example, if a pathologist deals with a testicular tumor, for example, and histologically it looks like pure seminoma, the pathologist should be really sure that it is really a pure seminoma, and he or she should examine the tumor very extensively, because there can be some hidden small component of non-seminomatous tumor. There can be a tiny choriocarcinoma or tiny embryonal carcinoma, which would aggravate the prognosis, which would change the prognosis, because it would mean that the overall prognosis will be worse, because the prognosis of those mixed tumors is usually driven by the most aggressive component, and the tumors are mixed very often. Which leads me to the second classification, to the pure and mixed tumors. As I said, pure germ cell tumors consist of single component. There is just one germ cell tumor. And mixed ones, they contain several components. Basically, any mixture of germ cell tumors is possible, and the biological behavior is based on the most aggressive component. So as I said, the pathologist should be really sure that he or she looks at a pure seminoma, for example, because there can be some tiny hidden component of some non-seminomatous tumor, which will aggravate the prognosis. And the mixed germ cell tumors are very common. They are not rare, they are quite common, because all of them originate from one single immature germ cell that has a capacity to give rise to multiple somatic and extrasomatic tissues. So mixed germ cell tumors are definitely not rare. So I said that the typical localization of germ cell tumors are gonads, testicles and ovaries. And the situation is slightly different in testicles and ovaries. So how is the situation in testicles? Here you can see the main groups of testicular tumors, and you can see that the germ cell tumors represent the most common group of primary testicular tumors. So the majority of testicular tumors are germ cell tumors, and seminoma is the most common one, is the most common type. It consists almost 50% of the cases. So the germ cell tumors are the most common tumors in testicles, and the most common germ cell tumor is by far seminoma. Less common are gonadostromal tumors, which means those are the tumors, or we call them also a sex cord tumors. These tumors differentiate towards Leydig or Sertoli cells, and they are not so common. Lymphomas. It is quite good to keep in mind that there can be also a primary testicular lymphoma, especially in older patients, because generally primary lymphomas of our testicles are not so common, but it is the most common group of primary testicular tumors in patients above 60 years. As I said, germ cell tumors are usually tumors of younger age, but if you deal with a testicular tumor in old patient, very often it can be a lymphoma. Then we've got a group of others, let's say. There can be tumors of paratesticular tissues, there can be some soft tissue tumors, which are generally not so common. And we shouldn't forget that even testicle can have secondary tumors, metastases. In testicles, we've got known precursor of the germ cell tumors. It is called germinal neoplasia in situ, and it's basically in situ germ cell tumor. So it's a precursor of invasive germ cell tumors. And it looks like this. You can find them as a dispersed, scattered cells in seminiferous tubules. And the cells look like big cells with pale cytoplasm and atypical nuclei. They basically look like seminoma cells, but they are just in situ. There is no invasion in surrounding stroma, in surrounding interstitium of the testicle. So this is the well-known precursor lesion. It's called germinal neoplasia in situ, and it's a precursor lesion of testicular germ cells generally, not only seminoma, but it's for all the germ cells, just germ cell tumors. We don't have such a precursor lesion in ovaries. Well, let's say there needs to be some. There needs to be something, but we just don't know it. We didn't recognize it. We haven't recognized it yet. But in testicles, it's well known. But there is a group of tumors, testicular tumors, that show no association with germinal cell neoplasia in situ. We've got 3 of them, and it's prepubertal teratoma, prepubertal Yolk sac tumor, and so-called spermatocytic tumor. These tumors were excluded because, as I said, they show no association with in situ component, and they've got a very good prognosis. It is questioned whether prepubertal Yolk sac tumor is really this case. Maybe we just didn't recognize, maybe there is some precursor lesion, we just didn't recognize it. But till these times, we still consider it a part of this group of tumors. And how is the situation in ovaries? The situation in ovaries is slightly different, because the germ cell tumors is definitely not the most common group. In ovaries, the most common tumors arise from superficial, so-called Müllerian epithelium. It's the most common group, but we won't talk about them today because it's a different topic. There would be serous, mucinous, clear cell, adenocarcinomas and adenomas. It's a different group of tumors, and it would require another lecture. So we want to talk about them today. And germ cell tumors in ovaries are not so common. They are not so common, and as you can see, they represent only 15 to 20% of all primary ovarian tumors. And in contrast to testicles, the most common germ cell tumor in ovary is mature teratoma. So the teratomas are the most common in ovaries, and they are usually mature. And as I said, there is no known precursor lesion. There needs to be some precursor lesion. The tumor needs to arise from something, but we just don't know it. Also in ovaries we can see gonadostromal tumors. In this case it would be the tumor differentiating towards granulosa cells, so which we call it a granulosa cell tumor. There could be thecomas, fibromas, fibrothecomas, but again it's different topic. And also in ovaries we can have some other tumors and metastatic tumors. Okay, and now let's proceed to individual tumors, and we will start with seminoma, or classic seminoma. We used to call it classic seminoma because that rare tumor, as I mentioned, the spermatocytic tumor, used to be called spermatocytic seminoma. So we had the classic seminoma and spermatocytic seminoma. But today we know that the spermatocytic seminoma has nothing to do with the seminoma, and we renamed it to spermatocytic tumor. So it's basically, we don't need to call seminoma a classic seminoma, it's just a seminoma. And as I said, the seminoma is characterized by a block of differentiation. So the neoplastic cells stay on the level of immature germ cells, and the tumor is usually found in testicles. As I said, it's the most common testicular tumor. And in ovary, it's quite rare. And in ovary, we call it dysgerminoma. But it's the same tumor, it's just a different name. It's usually a tumor of adolescents and young adults, so nothing strange here. If you will find something that looks like seminoma in different age, in very small children for example, always consider a possibility of mixed germ cell tumor. Because if you will find something that looks like seminoma in small children, it's not usual, and you should always examine the tumor very deeply and very extensively to rule out some small hidden non-seminomatous component, because it would worsen the prognosis. How does it look like? The gross appearance, the macroscopic appearance of seminoma is like this. The tumor is usually solid, homogeneous, whitish. There are usually no necrosis or hemorrhages. They are not typical. They are more typical for non-seminomatous tumors, typically embryonal carcinoma or choriocarcinoma. So if you see a tumor that is grossly necrotic and hemorrhagic, usually it won't be a seminoma. And microscopy is like this. I will switch to the pictures, and the seminoma consists of cells with quite typical appearance. The cells are quite large. They are oval or polygonal, with large nuclei. They are quite bright, often vesicular, with prominent nucleoli. And the cytoplasm of the cells is very bright, almost clear. It's because of glycogen. If the cell accumulates glycogen, generally speaking, if the cell accumulates glycogen in a bigger amount, the cytoplasm becomes almost clear, it becomes very pale, because the glycogen in microscopy is pale. You probably know clear cell carcinoma in kidneys is the same case. So those cells in seminoma are really pale looking, because they contain glycogen. The cells usually grow in solid sheets or strands. They can form lobules, and what's also typical is the numerous or rich mononuclear inflammatory cellulization in the interstitium. In other words, there is a lot of lymphocytes and plasmacytes in the interstitium of the tumor. It is a non-neoplastic component, and it's quite typical for seminomas. Sometimes there can be granulomas as well. In some cases, the cell can be more atypical. You can see scattered, really atypical looking, almost bizarre looking cells. And such subtype of seminoma is called anaplastic seminoma, and it is more aggressive. So it is good to keep an eye on the more prominent atypia in the tumor. And what about that spermatocytic tumor? As I said, it used to be called spermatocytic seminoma, but then we found out that there is no association with classic seminoma, and we call it spermatocytic tumor. It is quite a rare tumor, it is very rare, and the morphologic appearance is different from real seminoma, and it looks like this. Seminoma consists of one cell type, but the spermatocytic tumor consists of 3 cell types. You can see small cells that are dark and they resemble lymphocytes. Then you will have, let's say, middle-sized cells with more bright nuclei. And then you will have really large cells, which can be also multinucleated. And all those cells represent different stages of spermatogenesis. And as I said, the spermatocytic tumor is really different from classic seminoma. If we compare those two tumors, we can see a lot of differences. Classic seminoma consists of single cell population, as I mentioned. Spermatocytic tumor consists of 3 cell types. Classic seminoma progress from germinal cell neoplasia in situ. Spermatocytic tumor, as I mentioned, is one of those 3 tumors that show no association with neoplasia in situ. Seminoma usually affects young adults. Spermatocytic tumor is typical for older adults, let's say around 50 or 60. Seminoma is usually found in testicles, but it can be found also in ovaries or in extragonadal localization. Spermatocytic tumor is basically only in testicles. Well, never say never in pathology. I don't say it's impossible to find it somewhere else, but usually it's found only in testicles. And the seminoma has a good prognosis, and the spermatocytic tumor has an even better prognosis. The prognosis of such a tumor is very good. Okay, and now let's move to the non-seminomatous group. And as I said, this group as a whole is more aggressive. And embryonal carcinoma is a typical example of high-grade malignancy, both from the clinical point of the view and from the morphological point of the view. So it's aggressive malignancy with a worse prognosis than seminoma. It's usually found in testicles. In ovaries it's quite rare. And usually it's a component of mixed germ cell tumors. Pure embryonal carcinoma is not so common. Grossly, the tumor is highly necrotic and hemorrhagic, in contrast to seminoma. As I said, seminomas are usually homogeneous, pale, whitish, but embryonal carcinoma contains a lot of necrosis and hemorrhages. And histologically, as I said, is a typical example of malignant tumor generally, because you can see all the signs of malignancy in here. The cells are, let's say, cuboidal or polygonal. They show high-grade atypia. The nuclei are really atypical with prominent nucleoli, and there is a brisk mitotic activity, atypical mitosis included. The growth pattern of embryonal carcinoma is quite variable. Usually the tumor grows in solid sheets. It can form trabecules or tubules, but basically the growth pattern is quite variable. Yolk sac tumor. It's a tumor that differentiates towards yolk sac, allantoa, and extraembryonal mesenchyme. It's malignant as well. And quite often is diagnosed clinically, or you can have a clinical suspicion for such a tumor, because the neoplastic cells produce alpha fetoprotein. And this protein can be detected in serum. So there is an elevated level of alpha fetoprotein in serum. The yolk sac tumor is not the only tumor that can produce AFP. For example, hepatoblastoma, which is a malignant tumor of the liver in small children, it also produces a high amount of alpha-fetoprotein, so it is not 100% specific, but it is a good diagnostic clue. And for example, if you deal, as a pathologist, if you deal with a tumor that looks like a pure seminoma, for example, and there is a serum elevation of alpha-fetoprotein, you can be pretty sure that there will be some hidden small component of yolk sac tumor in the tumor. It will be in fact a mixed germ cell tumor, which is important for the prognosis. In ovaries, it affects usually adolescents and young adult women, but in testicles, the situation is more complicated because yolk sac tumor in testicles comes in two settings, as a prepubertal and postpubertal. And as I mentioned before, the prepubertal case shows no association with germ cell in situ tumor, at least we think so. It usually comes as a pure tumor and it is less aggressive. But the postpubertal one, it is more aggressive and it usually comes as a component of mixed germ cell tumor. So the pure yolk sac tumor in postpubertal age is not so common. And it looks like this. One of the typical features of yolk sac tumor is that the tumor contains a lot of myxoid substances. So the tumor is very gelatinous, loose, jelly, and grayish. And microscopically, I will again shift to the pictures. The cell looks slightly different from embryonal carcinoma. The cells are smaller, they are more pale, sometimes they are even flat, and they grow in let's say strands and ribbons, in reticular meshwork, and very often they form tubules or small cysts. So the microcystic appearance is quite common in those tumors. Sometimes the cell can have so-called hobnail appearance, which means that they protrude into the lumen of the small cyst. And the stroma of the tumor is very loose myxoid, full of myxoid substances, full of mesenchymal type mucin. What is very typical for this tumor is this. Sometimes the tumor can form structures that look like primitive developing glomerules. It is quite typical for yolk sac tumor, so it is good to find it, especially in cases in which you are not sure. And this structure is called Schiller-Duval body. So it's quite typical for yolk sac tumor. And last but not least, we've got choriocarcinoma. Choriocarcinoma is a malignancy that differentiates towards trophoblast. The both syncytial trophoblast and mononuclear trophoblast, which means cytotrophoblast and intermediate trophoblast. And the both components are necessary for the diagnosis. So for the diagnosis, we need a syncytial component and mononuclear component. Choriocarcinoma is aggressive malignancy. The dissemination is very early. Typical localization of metastasis is a lung. So there is a typical dissemination, especially into the lungs, which can be very early. And sometimes it's even the first clinical sign. So sometimes the patients come with the metastatic spread. They come with a cough, dyspnea, hemoptysis, and they will discover the metastasis of choriocarcinoma from ovaries, for example, or from testicles. So the early dissemination is sometimes even the first clinical sign. And choriocarcinomas are usually component of mixed germ cell tumors. The pure choriocarcinoma is quite rare. And similar to yolk sac tumor, also the choriocarcinoma cells produce something. In this case, they produce beta HCG, beta human chorionic gonadotropin, and it can be again a diagnostic clue. Grossly, choriocarcinomas are extensively hemorrhagic and necrotic. You will see extensive areas of necrosis and hemorrhages. So again, in contrast to seminomas, for example. And microscopically, again, I will move to the pictures. And as I said, you will see two components. You will see a syncytial trophoblast and mononuclear trophoblast. Syncytial trophoblast looks very wild and bizarre because even the normal physiological syncytial trophoblast is very atypical, and the neoplastic syncytial trophoblast is even more atypical. So you will find sheets of multinucleated cells or syncytia with abundant eosinophilic cytoplasm and very atypical hyperchromatic, even bizarre looking cells, nuclei. So this is syncytial trophoblastic component. And apart from that, you can see also a mononuclear component. This is mononuclear trophoblast. And you can see the cells are less atypical. They are, let's say, cuboidal or polygonal with less atypical nuclei, but still you can see cell atypia. There is a different, the cell varies in shape and size, and you can see quite brisk mitotic activity in here. And as you can see, the tumor is extensively hemorrhagic and necrotic. All of this is necrosis and bleeding. It's good to keep in mind one thing. The choriocarcinoma can arise in two clinical settings. It can arise in association with pregnancy. We call it gestational choriocarcinoma. And usually it arises in some pathological pregnancy. Usually it's molar pregnancy. So those are the patients with a complete or incomplete hydatiform mole. And in this terrain, a choriocarcinoma can develop. It can develop also in the setting of normal physiological pregnancy, but it is quite rare. So in these cases, the beta human gonadotropin can be quite helpful, because usually the molar pregnancy itself is associated with elevated levels of gonadotropin. But after you get rid of the mole, the level of the protein should go down. But if the level will continue to rise, that is a good clinical sign that there can be choriocarcinoma developing in this terrain. Second clinical scenario is a choriocarcinoma arising without association with pregnancy. And those are the germ cell tumors arising in testicles and ovaries as we know them, and we call it non-gestational choriocarcinoma. And this subclassification is very important because the non-gestational choriocarcinomas have a worse prognosis. And we will finish with teratomas. Teratoma is not one tumor, it's a group of tumors, and it can be quite misleading. Teratomas are defined as the tumors capable of terminal differentiation towards various somatic tissues. So it's usually a mixture of multiple somatic tissues, so it's usually a mixture of basically everything. You can see skin here, adipose tissue, neural tissue, respiratory tissue, and so on. Maybe the most important subclassification of teratomas is according their differentiation to mature and immature, as we will discuss in a minute. We can also subclassify it according to the number of germ layers which they form. If all the tissues in teratomas are from one germ layer, for example, ectoderm, we call it monodermal teratoma. And if there are tissues from multiple layers, we call it bi- or tridermal teratoma. Usually, we will find ectodermal tissue. It's the most common type of the tissue in teratomas, ectodermal tissue. So usually you will see skin, epidermis, and skin appendages. Sometimes that can be even neural tissue. It's the most common. And we can also subclassify it according to the localization. Teratomas can come in testicles, ovaries, or in extragonadal region. Especially the testicles and ovaries are quite important because let's say the biological behavior is driven by different things in testicles and in ovaries, and we will discuss it in a minute. So, as I said earlier, mature teratoma means that all tissues in the tumor are fully differentiated. So histologically, they are basically identical to their non-neoplastic counterparts. It's just the haphazard mixture of the tissues. But histologically, the tissue looks like the non-neoplastic counterpart. And they are usually cystic. And as I said, usually they consist mainly of the ectodermal tissue. So usually the most prominent tissue components are the skin appendages, and there can be also some neural tissue and so on. Immature teratoma means that some tissues are not fully differentiated and they look less mature. Usually it's a nervous tissue. So usually the immature component is a nervous tissue, and such tumor is considered malignant. And grossly, macroscopically, it's usually a combination of cystic and solid areas. And those solid areas often represent the immature tissue. So the pathologist should aim the sampling of the tumor to the solid areas, because there is a higher chance that you will catch the immature component. And as I said, if you will find the immature component in teratoma, it should be classified as malignant. So here is the example of mature teratoma. You can see the tumor is cystic. This is the wall of the cyst. And you can see that the wall is lined by epidermis. There is a squamous epithelium with a thick layer of keratin. This is the keratin layer. And then you can see that the lumen is basically filled with the keratin debris. Here you can see also some sebaceous glands that produce the sebum, again into the lumen of the cyst. And there are some hair as well. There is the follicle. So usually those tumors can be really nasty looking macroscopically, grossly, because it's usually cyst, and when you cut it, when you open it, it's full of sebum, keratin debris, and hair. So it can be a very nasty looking thing, and quite often there are also teeth. Here you can see that in some regions we can see also apocrine glands with some adipose tissue around. And again, here you can see some adipose tissue and the hyaline cartilage as well. But as you can see, all the tissues are fully differentiated. They are not immature, they are not atypical, they are fully differentiated tissue. That's why we call it mature teratoma. And here you can see that some cysts were lined by nervous tissue. This is the glial tissue. This is the glial tissue. And here you can see that the tissue is lined by one layer of, let's say, lowly cuboidal cells, and this is the ependym. And some cysts are lined by respiratory epithelium, as you can see here. Here you can see the columnar epithelia, which are ciliated. So some cysts are also lined by respiratory epithelium, and very often you can see hyaline cartilage in the wall of those cysts, so it can really resemble something like a primitive trachea, for example. And this is the immature teratoma. So if you find this in teratoma, we should call it immature one. And this is immature nervous tissue. All those small dark cells, they are basically neuroblasts. So they are very immature neural cells. There is a mitotic activity, as you can see. And you can see that the cells tends to form something that resembles primitive neural tube, which is also quite typical for these regions. So very often you will see those structures that look like neural tube with some lumen in the middle. So if you find this, we will call it immature teratoma, and as I said, the neural tissue is the most common, by far the most common immature type of the tissue, or is the most common tissue which can be immature in teratoma. As I said, to classify teratomas as a mature and immature is very important, and it is important especially in ovaries. Why? Because in ovaries, biological behavior of the tumor is driven by its histological appearance. Mature teratomas are considered benign in ovaries. Immature teratomas are malignant. And the vast majority of ovarian teratomas is mature. So in ovaries you usually find mature teratomas. In testicles, the situation is slightly more complicated because the biological behavior is driven mainly by patient's age. Also the teratomas, similar to Yolk tumors for example, we subclassify as prepubertal and postpubertal. And if you remember it, the prepubertal teratoma is the last tumor from those three who show no association with germinal cell neoplasia in situ. And in testicles, prepubertal teratomas are considered benign and postpubertal are considered malignant, regardless their histological appearance. So even if the postpubertal teratoma histologically looks mature, we still should consider such a tumor as a potential malignancy. So that is the important criterion. It is the important difference from the ovarian teratomas, because the ovarian teratomas are driven, the biological behavior is driven by the histological appearance, but in testicles it's not so simple, because even if the postpubertal teratoma looks mature histologically, it should be considered malignant, because those tumors arise from a single immature malignant germ cell which just differentiated. So even if the tumor looks mature, it should be considered malignant. But in reality, the vast majority of prepubertal ones look mature, and the vast majority of the postpubertal ones look immature. So usually there is a concordance between the histological appearance and biological behavior. But in some instances, theoretically, you can find the postpubertal teratomas which look mature, but even those we should consider as a potential malignancy. But in reality, the postpubertal ones are usually immature, and they are usually a part of mixed germ cell tumors. Pure postpubertal teratomas are quite rare. I've already mentioned dermoid cyst. As I said, it's a special type of teratoma, and it's an example of monodermal teratoma with ectodermal differentiation. So usually you will find the skin components. It's usually cystic teratoma, usually benign, mature, and usually it's a cyst filled with sebum, with keratin, with hairs, and microscopically the cyst is lined by epidermis with some skin appendages. So this is dermoid cyst. And then we have a struma ovari. Sometimes the teratoma can contain a thyroid tissue. It is not common, but it is not rare. And it's typical for ovarian teratomas. So especially in ovaries, the teratomas can contain thyroid tissue. And sometimes this ectopic thyroid tissue can be a source of ectopic hyperthyroidism. So those patients, those women, can show clinical signs of hyperthyroidism, but their thyroid glands are completely okay, they are normal, because the source of the hormone is the ectopic tissue in the teratoma. So it's good to keep in mind that this can exist. In very rare situations, it is extremely rare, but in very rare situations, we can have a normal somatic thyroid carcinoma in this ectopic tissue. So there can be a classic papillary or follicular thyroid carcinoma arising in this ectopic tissue, but it is very rare. Keep in mind one thing. The problem with teratomas is their classification, because especially the nomenclature of the teratomas can be very misleading. So I will try to recapitulate it. Teratoma in which all the tissues are fully differentiated and they resemble their non-neoplastic counterparts, this is called mature teratoma. And as I said, usually it's a benign case. If the teratoma contains some immature somatic tissue, usually immature neural tissue, it's called immature teratoma, which is considered malignant. But sometimes the teratoma can be mixed with other germ cell tumors. So there can be teratoma plus seminoma, for example, or teratoma plus embryonal carcinoma. So teratoma plus any other germ cell tumor. This is not immature teratoma. This is mixed germ cell tumor. So it's something different. So teratoma with any other germ cell tumor, it is not immature teratoma, but it is mixed germ cell tumor. And last but not least, we can have teratoma plus some non-germinal malignant tumor. There can be classic adenocarcinoma, squamous cell carcinoma, leiomyosarcoma. So if you have a teratoma with this non-germinal somatic malignant component, we call it teratoma with somatic malignant component. So please don't be confused by the terminology. Okay, and we are slowly getting to the end. Just a few sentences about the mixed germ cell tumors. I already mentioned them. It is a tumor that consists of more than one germ cell tumor, and basically any combination can be seen. The most common combinations are teratoma plus choriocarcinoma or teratoma plus Yolk sac tumor, eventually teratoma plus embryonal carcinoma. Very often there is a seminoma as well, but theoretically any combination is possible. And as I said, the biological behavior of such tumors is driven by the most aggressive component. In this example, you can see that some parts of the tumor consisted of highly atypical polygonal cells growing in solid sheets. So this is embryonal carcinoma. In some regions, you can see more pale-looking cells that form, let's say, strands and ribbons, reticular meshwork, or microcysts. So this is Yolk sac tumor. And also you can see that the tumor contained cartilage as well. So there is a hyaline cartilage with some bone formation in the middle. So there is also a component of teratoma. And you can see that the cartilage doesn't look completely mature. It's quite immature because it's hypercellular. There is a lot of cells which are haphazardly distributed, and even the cartilage cells, the chondroblasts, are a little bit hyperchromatic. So even the cartilage is not completely mature. So this is the example of mixed germ cell tumor with component of teratoma, embryonal carcinoma, and Yolk sac tumor. And this is the last slide, just a few last bits. I would like to mention two tumors, and maybe it would be good to remember one or two sentences for each tumor. There is something we call polyembryoma. Polyembryoma is a very rare tumor. It's a special subtype of mixed germ cell tumor, and what is typical for this tumor is this. You can find so-called embryoid bodies in this tumor, and these bodies, they resemble developing primitive embryo. So by this you will recognize it. It's called polyembryoma. And you should definitely remember gonadoblastoma. Gonadoblastoma is a special tumor. It's a combination of germ cell tumor and gonadostromal tumor. So it will be a mixture of germ cells, neoplastic germ cells, and neoplastic gonadostromal cells. I won't discuss the histology in detail because I think it's not necessary for the undergraduate level. But what you should know is that gonadoblastoma is almost exclusively associated with gonadal dysgenesis. So those patients with gonadal dysgenesis are in the increased risk of gonadoblastoma developing in this dysgenetic gonads. And gonadoblastoma itself is not malignant. It's considered a tumor of uncertain biological behavior, but it can be a precursor of malignant germ cell tumor. So some other malignant germ cell tumor can arise in the terrain of gonadoblastoma. So it's good to keep in mind that this is possible, and especially the patients with gonadal dysgenesis are in increased risk of this specific tumor. Okay, so that's all. Thank you again for the attention, and see you later with some other topic. Bye bye.